Right, let's jump straight into this. Today, we're tearing down a truly terrifying and highly deceptive neurologic pathology, anti-NMDA receptor encephalitis. We're skipping the basics. This explainer is a high-yield, integrative simulation calibrated strictly for those of you gunning for a perfect top-tier board score. We're talking 280 plus. It's a disease that strikes with a mask presentation, turns into a massive pathophysiologic avalanche, and demands an absolute operative mandate to save a life. So if you want to master the deep clinical integration required to flawlessly nail this complex diagnosis, you're in the exact right place.
So, let's track how this disease actually masks itself. The evolution here is incredibly rapid, and it almost exclusively targets young females. Now, the clinical picture strictly begins with what looks like a totally benign prodrome. We're talking just a few days of a fever and a headache. It looks exactly like a standard viral illness. But within weeks, this completely derails. The patient plummets into severe psychiatric symptoms. We're looking at acute anxiety, terrifying psychosis, and vivid visual or auditory hallucinations. And then, over the next few weeks to months, they hit profound memory loss and severe speech deficits, like mutism or echolalia. This whiplash from a mild viral-like onset to profound psychiatric and cognitive collapse, that's your absolute first major red flag.
The underlying mechanism driving all this chaos is honestly fascinating. Anti-NMDA receptor encephalitis is an autoimmune condition. What happens is the body forms antibodies that specifically hunt down and block the gluN1 subunit of the NMDA receptor in the brain. And why is that so catastrophic? Well, NMDA receptors are the essential proteins controlling our electrical impulses. They're absolutely critical for, well, everything. Human interaction, judgment, memory formation, and foundational autonomic functions like breathing. So when these receptors get blockaded, it's literally like cutting the main power lines. The brain's entire regulatory and cognitive infrastructure just starts to collapse.
Now, this brings us to one of the most dangerous clinical pitfalls you are going to encounter. Because severe memory loss and speech deficits follow the acute psychosis, these patients are frequently and incorrectly admitted to the psych ward. The admitting team assumes it's first-break schizophrenia or a brief psychotic disorder. I really want to explicitly warn you about this classic board exam trap. Assuming a psychiatric etiology in a young female who just had a fever and a headache completely delays definitive neurologic rescue. And honestly, falling for this doesn't just cost you points on test day. In the real world, it leaves your patient in imminent, life-threatening danger.
Because you see, the psychiatric phase is literally just the beginning. The neurologic escalation from here is violently aggressive. Step 1. Within weeks, the patient develops these pathognomonic movement disorders, specifically orofacial dyskinesias. You'll see repetitive lip smacking, weird chewing movements, and tongue protrusions. Step 2. Seizures start erupting. And then, we hit Step 3, the lethal wave. The patient crashes into profound autonomic instability. You're going to see incredibly dangerous fluctuations in blood pressure, wildly erratic heart rates, hyperthermia, and potentially fatal hypoventilation. At this point, the clinical signature has hit its absolute peak severity.
So what on earth is triggering this massive autoimmune cross-reactivity? Well, in over 50% of female cases, this whole devastating cascade is strictly a perineoplastic phenomenon. It is driven by a hidden ovarian teratoma. This is an absolute must-know association. The teratoma actually contains ectopic neural tissue, so the patient's immune system detects this brain-like tissue sitting down in the ovary, mounts a massive attack against it, and generates those antibodies against the gluN1 subunit. Those antibodies then cross the blood-brain barrier and go rogue, attacking the patient's own central nervous system.
To make absolutely sure you never misdiagnose this, let's strictly isolate the clinical variants. How do we actually differentiate autoimmune encephalitis from primary psychosis? It's pretty stark. Primary psychosis presents with normal vital signs, entirely normal cerebrospinal fluid, and zero complex movement disorders. Autoimmune encephalitis, on the other hand, comes with that autonomic instability, the classic orofacial dyskinesias we just talked about, and clear abnormalities in the CSF. The rule here is absolute. Any first-break psychosis in a young female that's preceded by a fever strictly mandates an exhaustive organic and autoimmune workup. No exceptions.
All right, once you spot this pattern, you have to lock in the diagnosis and stabilize the patient fast. The definitive diagnostic standard is finding anti-NMDA receptor antibodies directly in the cerebrospinal fluid. When you tap the spine, the CSF profile usually shows lymphocytic pleocytosis, though, just a quick aside, occasionally it might lack white cells entirely. Regardless, you have to send that fluid for perineoplastic antibodies.
And while you're waiting on those labs, if your clinical suspicion is high, the immediate pharmacologic rescue is aggressive immunotherapy. We're talking high-dose intravenous steroids, IVIG, or plasma exchange right out of the gate. And you quickly escalate to secondary therapies like rituximab if they don't rapidly turn around.
But here's the thing. Immunosuppression is absolutely not a cure if the trigger is still sitting there. That brings us to the operative mandate, which you need to treat as non-negotiable law. Step 1, you recognize the encephalitis signature. Step 2, you immediately launch an exhaustive search for the underlying tumor. Because the trigger is an ovarian teratoma, your exact next step is a pelvic ultrasound or a pelvic MRI. Step 3, if you find a teratoma, its immediate surgical removal is absolutely required. Excision is strictly necessary for clinical recovery, period. It's the only definitive way to stop the antibody production and prevent a relapse.
Okay, let's pull all of this together into a master case blueprint that simulates the absolute highest levels of clinical testing. Imagine this. You have a 22-year-old female presenting with a 10-day history of acute onset paranoia and hearing voices. The history explicitly mentions recent college stress. Now that right there, that's the diagnostic trap deliberately designed to tempt you into diagnosing a schizophreniform disorder. But look closely at her physical exam. She is currently exhibiting repetitive chewing movements, and her heart rate is wildly fluctuating between 50 and 130 beats per minute. The prompt strictly demands to know the most appropriate next step in diagnostic imaging.
Here is your assessment execution. You're forced to choose between A. Non-contrast brain CT, B. Pelvic ultrasound, C. Brain MRI with gadolinium, D. Carotid ultrasonography, or E. Chest CT. Take a hard look at these options. Think about it. Most clinicians, when faced with an acutely altered, actively psychotic patient, are going to instinctively reach for head imaging. It's a reflex. But you have to bypass those standard psychiatric and neurotrauma assumptions.
And here's our exhaustive, choice-by-choice breakdown to prove why. Option A, the brain CT, is a total distractor. It completely fails to target the underlying paraneoplastic trigger and severely delays definitive care. Option C, the brain MRI, sure, it might show some T2 hyperintensities in the hippocampus, but it totally fails to locate the primary tumor source actually driving the pathology. Option D, carotid ultrasound, is for vascular occlusion, completely wrong for autoimmune encephalopathy. And option E, chest CT, well, that's the imaging of choice for Eaton-Lambert syndrome linked to small cell lung cancer, not what our patient has. Therefore, option B, the pelvic ultrasound, is the strictly correct operative mandate. You recognize the anti-NMDA signature, the psychosis, the dyskinesias, the autonomic instability, and you forcefully selected the exact imaging modality that directly visualizes the ovarian teratoma, the literal source of the lethal antibodies. Mastering this progression doesn't just guarantee you a top score, it equips you to save a life when every single second matters. So I'll leave you with this. What other deceptive syndromes are currently hiding behind a psychiatric mask in your clinical practice? Keep pushing your diagnostic boundaries, and we'll see you in the next explainer.